Yeah.
Whenever you're ready, guys, and we'll try and obviously keep as quiet as possible here.
Good morning. My name's Anne-Marie Campbell, Community Respiratory Physiotherapist. This morning we're going to talk to you about the introduction to airway clearance techniques. You'll be familiar with some of these techniques from the past and some of you more recently. We're going to be discussing active cycle of breathing, postural drainage, perks and vibes, autogenic drainage, positive expiratory pressure, oscillating PEP, breath stacking, assisted coughing, and high frequency chest wall oscillation. Don't be worried, we're actually focusing on the main techniques that will be familiar to most of you. The latter techniques will be discussed on other talks and gone into in more detail in those. The types of patients that you'll be treating potentially using these techniques are obstructive patients with secretions who are unable to clear them effectively. For example, cystic fibrosis patients, bronchiectasis, COPD with secretions, asthmatics with secretions, and ciliary dyskinesia, where there's a problem with the motility of the sputum and the cilia. Types of patients then also in restrictive lung disease with secretions can be post-operative patients, patients with muscular dystrophy, spinal cord injuries, myopathies or thoracic cage abnormalities, and you'll be familiar with these types of patients as well. The active cycle of breathing has several components, okay? We start off with the breathing control element, the thoracic expansion exercises, and thirdly, the forced expiratory technique. The active cycle of breathing starts off with the breathing control, where the patient gets control of their breathing, particularly if they're breathless, and it just settles them down into the technique. 3 to 4 deep breaths, followed by breathing control, deep breaths, breathing control, and then huffing, followed by a cough if they have secretions to clear. The definition of breathing control, it's a tidal breathing at the patient's own rate and depth. The person is encouraged to relax the upper chest and shoulders and to use the lower chest diaphragmatic breathing as much as they're able to. Thoracic expansion exercise emphasise inspiration to total lung capacity. A 3-second breath hold at the end may be used if the patient's able to do that. Expiration is relaxed. Repeat 3 to 4 breaths followed by your breathing control, and it creates an interdependence between lungs, collateral ventilation, where we have the interbronchial channels of Martin, the bronchial alveolar channels of Lambert, and the alveolar pores of Kohn. You'll remember that from your physio course back in Jordan's time potentially. The forced expiratory technique, 1 to 2 huffs combined with breathing control. The huff shouldn't be harsh, as it'll shut down your airways and shutter them. So, for example, you can use a tissue or a wee mouthpiece with the patient instead, which is a gentler technique, and we'll be showing you that later on. Huffing can be divided down, which may be new to you, into a graded huffing technique. Graded huffing is a very effective way of moving secretions from different areas of the lungs. It utilises different breathing cycles and combines with different lengths of huff out to target more specific areas of the lung. So to divide it up, the lower lobes or the bases are small airways. Think small. Small airways, small breath in, long, slow huff out. And that's right out, right out, right out. We'll demonstrate this. To target the middle areas of the lung, we want to take a medium breath in and a medium huff out. And to target the upper chest or upper airways, deep breath in and a short, sharp huff out. So that's a good forced one. Graded huff tips, as we said before, use a tissue. A mirror can be used for fogging up or your glasses. Use a mouthpiece to maintain an open glottis, and kids can play games as well. Coughing. coughing, you need to cough correctly or teach your patient to cough correctly. Repeated coughing, as I say, is just going to shut down the airways, so cough, cough, cough. We want to avoid that. Deep inspiratory breath, ensure good positioning to ensure a strong cough. And you'll see in later talks the use of peak flow can be used to assess and monitor cough, particularly in patients with neurodisabilities. The FET or forced expiratory technique, atelectasis or lung collapse is compensated by these thoracic expansion exercises. Airway instability due to dynamic compression is overcome using this, and the breathing control prevents airflow obstruction, as we've mentioned before. Active cycle of breathing causes greater independence for patients, helps avoid hypoxemia. Patients with possible gastroesophageal reflux, if done with postural drainage, can be introduced from a young age, can be flexible to suit the individual, but patients need a good level of cognition required for effectiveness. So it's not good for the patients with lower cognitive impairment because there's no carryover. Maximise the benefit in line with medications, and by that we mean, it's better to do it maybe after your bronchodilator inhaler or nebulizer, or after your mucolytic therapy as well. We're firstly going to demonstrate the active cycle of breathing, and you'll see here we've got some Southern Trust active cycle of breathing leaflets. These are available on the physiotherapy tile on SharePoint for you to download and print off if you're doing this with any of your patients, just to help verify the technique as well. So you need very little equipment for the active cycle of breathing. You really need a tissue if you've got one for the technique, but also if a patient is coughing up secretions, you want some tissues to hand so they can cough and throw them in the bin then as well. Obviously, if we're treating a patient with suspected COVID or any other potential infectious disease using your PPE equipment, you'll have that on as a matter of fact, and you will get the patient to cough away from you, to turn their head. That's quite important as well, so that you're minimising your risk and exposure as much as possible. Okay, so Gillian is our model here today. So Gillian, we'll get Gillian to sit and relax on the chair, feet just on the floor resting. If you've got an armchair with arm rests on it, that's great. That facilitates relaxation of the upper chest and the shoulders. If not, quite useful to facilitate relaxation is get the patient to put their palms up. Get Gillian just to breathe out and relax her shoulders. Encourage her to relax her upper chest as well. And the first thing we're going to start off is with the breathing control technique, and that's using the diaphragm to breathe. The diaphragm's our dome-shaped muscle under the lungs. So we'll get Gillian just to put her hand on her midriff there, relaxing her upper chest and her shoulders, and then breathing nice and gently into her hand. Okay, like so. Obviously, if you're putting your hand on your patient, you have to ask their permission, that they're happy that you do that. And I do like to put my hand over their hand when they're doing this, so I can feel if they've got the technique right, okay? So, nice and softly into the tummy on the breath in, and then let it go. So there should be no strain in that breath whatsoever. And that's how you start off, just to help them relax into the technique, and also if you have a very breathless patient, to help them calm them down to start off, okay? So 3 to 4 deep breaths, or in some cases a lot more than that. You just have to see what your patient needs. Then I like to move in along the sides of the chest wall. And just place your hands like so you can feel the expansion of the lungs. And then Gillian, if you could take a breath in for me, and in, and in, and in, and hold it in, hold it in, hold it in, and sigh out. So this is the demonstration of your thoracic expansion exercises. So in, and in, and in, and hold, and hold, and hold, and out. Okay. So you're aiming for 3 to 4 breaths with that as well. So in and in and in and in and hold and hold and hold and out. You will have some patients who cannot manage end inspiratory hold, and that's okay. Okay, and one more for me, Gillian, and hold it in, hold it in, hold it in, and out. So using your hands, you can feel is expansion equal and in both lungs, or how that's feeling, or if there's reduced expansion. Then Gillian will get you go back to your breathing control. So she needs time to settle her breath so she doesn't get dizzy or hyperventilate. So nice and settle into the tummy and let it go. Into the tummy and let it go. Some patients find this technique really difficult and their breathing is quite jerky. So sometimes closing their eyes can just really help them get the feeling of the breath rather than getting very uptight about it. Okay, so once she's settled, or your patient is settled, then we're back to our thoracic expansion exercises again. And in and in and in and hold and hold and hold and out. Okay. Now, you're ready. Breathe in again. Right in, right in, right in. Now, some patients' shoulders will be up here, so I would just softly encourage them down and let it out. And in again, and in and in and in and hold and hold and hold and out. Okay, super, Gillian. Okay, now we're going to move on to the huffing and show you how to do the graded huff. Remember, the graded huff is targeting different levels of the lungs. So we're going to teach you the small breath in, long, slow out, and that's the smaller airways we're targeting. So Gillian, if you want to get your wee huffer mouthpiece, if you have these to hand, great. If you don't worry about it, okay? This is just really for technique only. They don't have to have this device to do it. So if you have, just put it behind your teeth, seal your lips, and take a small breath in and a long, slow sigh out. So it's very gentle, and squeeze it out, squeeze it out, squeeze it out, squeeze, 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 squeeze. And small in again and out. And out. Long, slow out, squeeze, 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 squeeze. Okay. Now, sometimes your patient will be ready to take a big gasp in, but try to tell them it's a small breath in. Now, her airways are nice and clear at that. I use my hands so I can feel for secretions. If I feel anything rattling about, I know she's got secretions at that level. Okay, but she's nice and clear, so we'll move on to the middle airways. So it's a medium breath in, Gillian, and a medium huff out. Okay, so this is a little bit stronger. Breath in and a medium huff out. With this medium huff out, you don't keep going for this one or that will cause the small airways to collapse. So medium in, medium out. That's lovely. And out. Lovely. So that's nice and clear. So we move on to the upper airways. Again, if you have a lot of secretions at mid-lung level and you hear it rattling, you need to focus your treatment on that area until they get them shifted. Okay, so try a big breath in now for the upper airways and a short, sharp breath out. Okay, good. And a big breath in and a short, sharp blast out. Okay, and then we're going to get her to turn her head and give a good big cough. Okay, lovely. Now back to your breathing control to recover. Okay. So that's one go of the cycle. So you can repeat that as many times as the patient needs until they get fatigued or their chest becomes clear. That can be done as often as needed. We'll just demonstrate, Gillian, the tissue as well as an alternative technique for your patients. Okay, Gillian, if you just want to show us then how you use the tissue and you can see the flow with the movement of the tissue. It's good visual feedback for the patient. Okay, lovely. So remember, it's that gentle, like blowing out of a candle. That's lovely. Okay, In paediatrics, you can use the active cycle plus or minus manual techniques, and to be honest, it's the same with adults. When combined with postural drainage, it accelerates the clearance of secretions from peripheral lung regions. Laughing or bouncing can be effective means of lung expansion in infants and babies. Children from 2 years of age can be encouraged to deep breathe with bubbles, paper, windmills, candles, blowing down stacked cars, straws. Use your imagination on this one. Use huffing with cotton balls as well. Older children greater than 7 can be taught the active cycle of breathing, as long as they're able to understand. Postural drainage, perks and vibes, that's more the traditional chest physio that would have been about years ago, but that still has a place, it still can be used. And it's using gravity-assisted positioning based on the anatomical position of the airways. All airway clearance techniques must include a method of ventilating all areas of the lungs. Positioning should be to improve ventilation by enhancing airflow to the obstructed area of the lung, and it's used very regularly in paediatrics in particular. Percussion is a rhythmic clapping using a closed wrist and cupped hand over an involved lung segment. It's thought to produce an energy wave which is transmitted to the airways, loosening secretions from the bronchial walls. Fine oscillations and exhalation apply our fingertips with an infant. The amount of pressure applied is modified according to size and the condition of the child. It's difficult to achieve with every breath in an infant due to their increased respiratory rate.
We'll now demonstrate perks and vibes on a child. This is a technique that can also be used in adults, but is most commonly used in paediatrics. This can be done on a bed with the child supported, or equally with a younger child over your knee. So if we place the child in side lying, this will target the mid and the lower zones. Using a cupped hand and a loose wrist, we can practice this on ourselves first, where you will hear a hollow cupping sound. If you're hearing a slapping sound, you know that you have the technique incorrect. So placing the child in side lying, you can support the head and move the arm out off your way to do the technique, moving up and down to cover all areas of the lung. To target the upper zones, we'll move the child into lying on their back and again supporting their head. This will move the secretions into the central airways, which may stimulate a cough, and this can then be suctioned away. So again, with vibes, the child can be placed in, or the adult, in both side lying or in supine lying or in sitting up. When the child is in side lying, you're supporting the head and again, putting your hands on the front and on the back of the chest. You're feeling for the child's breath out, and as they take the breath in, follow up and press down, applying gentle pressure with the breath out. This is only done on their breath out.
Things to consider with a child. When applying to infants, it's important to stabilise the head to avoid any risk of intracranial hemorrhage. Coordinate with feed times carried out 1 hour after, or avoid or modify your techniques in the presence of osteoporosis, loss of skin on the chest wall, maybe due to scalds or burns, pain and rib fractures. Other cautions in paediatrics as well can be bronchospasm, recent or severe hemoptysis, severe clotting disorder, surgical emphysema, unstable angina or arrhythmias, raised ICP, intracranial pressure, and pleural effusions. I'm going to move on now to the PEP devices. So PEP stands for the positive expiratory pressure, and this is really breathing against an expiratory resistor maintains a positive pressure within the airways. This promotes effective secretions clearance to the proximal airways due to positive interbronchial pressure. Air moves behind obstructive airways via these collateral channels. We've mentioned earlier the interbronchial channels of Martin, bronchoalveolar channels of Lambert, and the alveolar pores of Kohn. Airflow resistance is increased within the conducting airways by the presence of retained secretions or airways collapse. PEP therapy allows more air to enter the airways through collateral channels during inspiration than escapes during expiration. This results in a pressure gradient that builds up behind sputum plugs, moving secretions to central airways from where they can be more easily moved with some of the other techniques. Increased pressure acts to hold the airways open during expiration, preventing premature airway closure and thus reducing air trapping in the lungs. And it increases functional residual capacity and tidal volume. Types of PEP that we have is the low pressure PEP, high pressure PEP, and oscillating PEP. So to be fair, mostly you'll see the low pressure PEP through the Mediflow PEP, which we'll demonstrate later on, or the oscillating PEP. For example, the Flutter, Acapella, Aerobica, Easy PEP. Okay. Oscillating PEP, which you'll see a lot in the community and potentially in the hospital as well. This uses a counterweighted plug and magnet that interrupts expiratory flow through a pivoting cone at frequency of 0 to 30 Hertz. Oscillations are generated during expiration with travel through the airways, vibrating and mobilizing secretions. As before, the PEP component creates a positive black pressure during expiration that splints open those peripheral airways, temporarily increasing your functional residual capacity. The expiratory flow also moves secretions into the central airways where they can be expectorated with graded huff and cough, just like your ordinary PEP. The Acapella can be used in a cycle of breathing, similar to the active cycle of breathing. So you start off with your breathing control as before, 3 to 4 breaths potentially, or whatever your patient needs. 12 to 15 breaths with your Acapella. Remove your Acapella, do your couple of huffs at your different lung levels, your graded huff, and cough and clear if you need to. Back to breathing control and starting your cycle again. We'll be demonstrating this in a wee while. The number of breaths and cycles should be individually prescribed depending on the amount and viscosity of secretions, fatigue and other individual factors. An average treatment would be 10 times 10 cycles, which can take 15 to 20 minutes, once or twice a day. But the important thing to remember, if you have a patient with a bigger secretion load, they need to do it more often, and those with an acute exacerbation, they need to do the treatment cycles more often. The Aerobica is another oscillating PEP therapy system, resistant settings capable of pressure between 10 to 30 centimetres of water, and it also allows inhalation and exhalation without removing from the mouth. It can be used in any position or orientation, these oscillating PEP devices. So they can be used in lying, sitting, high side lying, any of those positions. They're very lightweight and ergonomic design, fits comfortably in the hand. Patients like something in their hand to use. I think it helps compliance with treatment as well. They're easy to clean and disinfect. They're dishwasher safe as well, and they're a cost-effective treatment option. Effective aerosol delivery when combined with nebulizer treatments as well. So there's that option to entrain your nebulizer into these systems as well.
Alrighty, whenever you're ready.
Okay, so what we're going to do today is to do a demonstration of the Mediflow Duo. This is a piece of equipment that should be available in any department or ward situation. There usually is a ready supply of these. More often than not, we are using these in a different manner. We're using it to increase lung volume, but this piece of equipment can be used as a low pressure PEP. I have it set up as a low pressure PEP. The bung is at the bottom, and the tubing is at the top. If you are using it for lung volume, what you would have it would be the reverse way. So what you have to remember whenever you're using it for as a low pressure PEP is that the grading is the yellow writing. So it is graded from 1 to 5. Okay, so whenever you are using it with a patient, again, you would like to have them sitting, resting with their elbows resting on a table. And again, the patient should be doing their diaphragmatic breathing. Whenever they go to use it, okay, we have it resting there. They're going to put it into their mouth. And what they're going to be doing is a slightly larger than normal breath. So about a 3/4 breath. So it's slightly larger than your normal tidal breath in. And whenever you're doing expiration, you're breathing out through resistance in order to create a back pressure of about 12 to 15 centimetres of water. So the ball should float, and you'll see that there. Okay, so the breathing should be active, but it should not be forced. And you want to repeat this about 10 or 15 breaths with your patient. Again, until possibly they fatigue or until you can hear the secretions loosening. And as soon as that occurs, then you would do your graded huffing and your cough, and you would repeat that cycle until their chest clears. Okay.
Okay, we're just now going to demonstrate the a cappella PEP device, positive expiratory pressure device, and again, the leaflet's available on the physiotherapy SharePoint for you to download as well. So the a cappella device here, we usually get our patients, you can do it in various positions really, but for the purpose of the demonstration here this morning, we're going to get Eileen just to sit on the chair and to rest her elbows on the table, okay? And then she can lift the a cappella in her hand, keeping her head upright, so that keep an open glottis. Just put that behind the lips, seal your lips nice and tight, put it behind the teeth actually as well, encouraging her to relax her shoulders, and we'll be asking for permission again to put her hands on for treatment with the a cappella. Okay, so we'll get Eileen, as we discussed before, we'll have her starting off at level 1 here, resistance 1 on the a cappella, which I'll show you in a wee minute how to change that. And we're going to get her to take a nice deep breath in with the a cappella, 3/4 of a breath, hold it in, hold it in, hold it in, and then out through the device. 2, 3, 4. Just to end. And in, and hold it in, hold it in, hold it in, and breathe out. 2, 3, 4. Okay. And in again, hold it in, right in, and hold, 2, 3, and out, 2, 3, 4. As Eileen's doing that and getting comfortable with the technique, you can put your feel for the diaphragm just under the breastbone, okay? And breathe in, Eileen, and hold it in, hold it in, hold it in, and then engage that muscle on the breath out. So push your diaphragm against the therapist's finger. And in, remember to release that as you're breathing in, and then and out. 2, 3, 4. Okay, so this breath out needs to be active, but it doesn't need to be forced, okay? So it's not a passive breath, it's an active breath. Otherwise, you're not generating enough flow behind it to generate the vibratory component of the a cappella. Okay, so we'll go again, and in, and in, and hold, and hold, and hold, and out. 2, 3, 4. If your patient's able to go long after 4 for the breath out, I up my resistance, okay? So you're aiming for a breath out of count of 4. And hold, and out. 2, 3, 4. Another tip is if your patient's cheeks are flapping on expiration, pinch them like Eileen's doing, and that maintains the pressure. Okay, you're not losing that pressure into the cheeks. And one other important thing is that as she's breathing in and out, she must maintain the seal at the mouth at all times, otherwise you're breaking that pressure. So we're looking for a build up of pressure over maybe 8 to 10 breaths. But again, that's very patient dependent, whether they're able to do that. And remember, after each cycle, then you're going to ask Eileen to do her breathing control. So at her tummy, at the belly breathing again. Okay, so breathe in the diaphragm and then let it go. And into the tummy and let it go. So really important to have that wee break in between repetitions. And then when she's ready, she starts the cycle again, okay? Okay. Lovely, Eileen, thank you. So we just want to show you how you take the a cappella apart, and also that you have the option of using a face mask, which is good for patients who have a facial palsy or droop on one side for some reason. So the a cappella, the component parts are the mouthpiece, so you just turn that round. We've got little grooves here, so pinch and lift, and you lift the rocking device out. So it's just these 3 component parts are for washing, and they can only be put together one way after they've been cleaned. Got a little magnet here and a bit of metal here. It's really important that they're dried thoroughly so they don't rust, otherwise that will affect the mechanism. So when putting it together, it can only go one way, the rocking device. You pinch that down, a little bit of pressure here, and then put the mouthpiece on over that lip. Okay. Similarly, this is how the face mask is put on. Thank you. That's great, thank you. So now we're going to demonstrate the Aerobica PEP device, Aerobica Positive Expiratory Oscillating Device. Very similar technique to the a cappella. So if you focus on the a cappella demonstration, then the Aerobica is very similar, just an alternative device that may be available to you in the community or in the hospital setting for your patients. Again, you'll find these on SharePoint. Okay. So Eileen, ideally, she can sit again on the table resting her shoulders, but I've said before, this can be used in any position, lying, side lying, anything at all. So Eileen, if you want to put the Aerobica in your mouth. Now I've set it at down at number 1 as well in terms of the resistance, okay? So we're taking a breath in, and holding it in, and then out through the device. 2, 3, 4, and in, 3/4 of a breath, hold it in, and out, 2, 3, 4, and in, hold it in, and out, 2, 3, 4. So as your patient's getting used to that technique, with the permission, again, you want to place your finger on the diaphragm, below the breastbone. In, 2, 3, 4. So, and in, and as Eileen's breathing out, you're encouraging her to engage that muscle and push against your finger. So she's engaging the diaphragm on the breath out. Lovely. And again, I'll show you how to pinch your cheeks if you have a patient with loose cheeks and who's losing a lot of pressure. And suck in 3/4 and hold it in. So your end expiratory hold, and out 2, 3, 4. Okay, suck in. hold it in and out. 2, 3, 4. Okay, lovely. And Eileen's going to show us how to take aerobica apart. Okay, got a mouthpiece, lifting these component parts. Okay, so these are all the component parts separate. Just to know that the aerobica and the a cappella are both dishwasher safe. Warm soapy water is sufficient and can be sterilised once a week. All the cleaning instructions are also on each individual leaflet as well for the patient and as per manufacturer's guidelines. So Eileen's just showing you that can only go back in one way as well. And then if we show the dial of the resistance, Eileen, we've got little numbers along the side there as well. So exactly the same as the a cappella. If you're breathing out way longer than the 4 or 5 seconds out, then you need to increase your resistance for your patient. So increase your number on the resistor. Right, thank you. Contraindications or precautions with oscillating PEP therapy, or indeed any PEP therapy, is a pneumothorax, okay, active hemoptysis, severe cardiovascular insult or disease, arterial aneurysm, bullae in the lung, post-lung surgery, post-lung transplant if there's any concern with the healing of the anastomosis, or post-lobectomy. Similarly, oscillating PEP favours air leaks. So in summary, the effective airway clearance requires adequate ventilation and expiratory flow to clear secretions, but there's an increased range of active cycle or airway clearance techniques available to allow individual treatment plans for patients, taking into account the effectiveness of technique, patient preference and choice, and obviously what's available to you as a physiotherapist.